Thanks, Connor. Hello, everyone. Good afternoon. I'm going to be your postprandial stimulation, so as I see you nod off, I've actually been criticized for speaking very loudly, and one of the reasons for that is that all my students are sort of nodding off. It's a way to keep them awake. Excuse me. So it's a real pleasure to have been asked to come and speak to you while we're here in your beautiful country. My wife and I are going to travel for the next 2 weeks around the west and north, so we're really looking forward to seeing more of Ireland. My job today is probably to give the lecture that should have started the day, but I was at the other meeting, and this lecture is going to introduce you to the way we in our field try to define this disorder. What is dystonia, and how do we classify it? And you might wonder, why do we bother doing all of this? Well, in fact, we've got to talk the same language. The doctors that are trying to deal with this very difficult condition need to be sure that we're talking about the same thing. And as I'll point out later, there are a lot of things that can fool us and make us think that it could be dystonia. And so what we've done over the years is tried to define the disorder and to try to put some skeleton into the classification and put some process to the phenomenon. So let's get started. The term dystonia was first coined by this guy, Oppenheim, in 1911. In fact, as you probably all appreciate, the appearance of patients with various forms of dystonia can sometimes be very specific, and so pictures of people, paintings of people that might have had dystonia were available and in the literature and in art for probably centuries before this, but it was Oppenheim that used the term, and he used the term in a way that is no longer utilized, and that is dystonia musculorum deformans. So he assumed that this was a muscle disorder and that it deformed the appearance of the individual, and yes, that can occur, but that is one of the things that causes misdiagnosis if you wait for somebody that just has this abnormal posture. So he's emphasizing that the muscle tone is abnormal, varying between loss of tone and increase in tone, and he says not exclusively elicited by voluntary movement. So these next two, shortly afterwards, objected to his terminology and preferred the term torsion spasms, and argued that this was varying muscle tone, and that was the clinical hallmark of the disease. So this was not quite ignored, but really not attended to very much for a long time thereafter until the 70s. And this man here is probably one of the most important living people in the field of dystonia. Unfortunately, he's been ill lately, but this is Dr. Stanley Fawn from New York, and Stan is our father and grandfather of the field. He really spent a huge amount of his professional life working to try to do good for patients with dystonia. In 1975, he established the first international symposium, and he and his colleagues, my mentor, I trained in England for a couple of years under a man by the name of Professor David Marsden, and Marsden and Fawn worked together in the field of dystonia, and they recognized that these forms were actually part of a whole. So nobody until that time realized that there were similarities and overlaps between things like your eyelids being involved in blepharospasm, the involvement of the mouth, the neck, the speech, the difficulty with writing, and it wasn't until Marsden and Fawn met and discussed these issues carefully that they began to realize that there was a reason to do some lumping. Now, we need to split as well if we're going to understand, but we really needed to understand the overlap and similarities. In 1984, the same group, now working with the Dystonia Medical Research Foundation, or the DMRF, decided to define the disorder, and they called it a syndrome consisting of sustained muscle contractions, frequently causing twisting and repetitive movements or abnormal postures. So you see what's happened already. They're recognizing that it's not just the postures, but it's the movements that also need to be recognized. And that was really very important. And it's one of the reasons for misdiagnosis so frequently. A lot of doctors don't recognize that there are quite a wide variety of movements, not just the abnormal postures. So I'm just going to give you a little bit more history. It evolved. The classification of this disorder evolved. And again, Stan Fawn. You just see how much contribution this man has given to us. So in 1976, he used certain terms. I'm not going to go through the details. Primary dystonia, that term you'll hear repeatedly, and I'll come back to that in a minute. Then the DMRF funded 3 international programs as centers of excellence. And when I started to train, these were the 3 world-renowned centers of excellence for dystonia: Fawn in New York, Marsden in London, England, and Calne in British Columbia. And they started to talk about dystonia on 3 axes: the age of onset, the distribution, where in the body the dystonia is seen, and what is the cause. You'll see this word repeatedly, etiology. That just means cause. And then Fawn, Bressman, Marsden, 98, used some other terminology. Then Susan Bressman, who trained with Stan Fawn in 2004, provided some additional flavor to this etiology. And then the European Federation of Neurological Sciences became involved and wrote some guidelines in 2011. So we got a problem here, and this is one of the reasons that we spent so much time doing this, and I'll tell you a little bit more about what a group of us have done in trying to put some sense to this. The problem is that the term dystonia was used to describe a movement disorder, a syndrome. People said, I have dystonia, as if it's a specific diagnosis or a cause, too. So you had 3 things that this term referred to, and this term primary dystonia usually was used to describe people, and most people in this room probably have what's called, or used to be called, primary dystonia, meaning that that's all you have. You don't have dystonia with spasticity in your legs or liver disease or some other illness to suggest a broader condition. You have isolated, what we term now isolated dystonia. But this term primary dystonia was used, and it created a lot of confusion. And then there were other terms that were used. Secondary, meaning secondary to some cause that you can define. Dystonia plus, meaning you got dystonia plus something else. And then heredodegenerative. You have a disease like Parkinson's disease may be associated with dystonia. And so diseases that could be sometimes hereditary and often related to degeneration of the brain. So again, you see there's a bit of a mess here, and for a variety of reasons, we felt that we needed to reconsider how to classify. Now, dystonia is a rather unusual thing, and I'm going to tell you things that some of you have experienced and know about, but maybe some haven't heard. One of the unique or unusual aspects about dystonia is that it is brought out by movement or action, and sometimes that can be very action-specific. You may only have dystonia when you write. You may only have dystonia when you jog, for example. We're now recognizing joggers' dystonia in the leg. You may only have dystonia when you speak. So a variety of specific actions may induce dystonia, and then as it evolves, it becomes less specific to the original action. So somebody who had dystonia only when they wrote now starts to have dystonia when they use the hand for other tasks. So it becomes less selective. Then, if you're watching somebody who is having progression, and sometimes it stays at that top level. We see patients who remain isolated to an action-specific dystonia, but then it may progress, and when it progresses, you may see what's called overflow, and it may overflow to other muscles that weren't originally involved, or you may see somebody moving an opposite limb and the flow of the dystonia comes out in the originally affected limb. And after a period of time, it may occur at rest. So what was only occurring with action may now be present when we just view the patient if they're simply resting. And if we see dystonia at rest to begin with, it's there all the time in one position, we often have to think that there may be a cause that we can define. Not always, but that's sometimes a clue to the fact that we are going to find a cause. Now, there are a couple of other things that are rather unusual about dystonia, and some of you may have experienced some of these things. The term sensory tricks, or in the French, a geste antagoniste, someone with cervical dystonia where the head is turning, a light touch to the chin, or holding the hand behind the neck, or resting the head against the wall, can resolve the problem. And that's really quite interesting. Somebody with very bad dystonia of the jaw, putting a little toothpick in their mouth often will relieve the dystonia completely. And this was one of the reasons for many years that people thought dystonia patients were crazy. They were psychological, or that was the main cause. It was a psychogenic problem. And it was only after a time that we began to realize, in fact, if you have this, this is characteristic of a non-psychological cause. This is really dystonia. Sometimes we see, less commonly, movements that come out sort of paradoxically. It's relieved by action, the opposite to action induced. And then there are a group of dystonia disorders where the movements only occur like epilepsy. So if anybody knows you have a seizure, you may be normal between seizures, but when you have a seizure, you have an epileptic seizure. The same can happen with certain forms of dystonia. So you have normalcy between, and then you have a period where you're very dystonic, and then the dystonia goes away and you're fine again. And sometimes that's triggered by rapid movement. Somebody jumps up and their arm goes out, and it stays like that for a few seconds and it goes away. That's called paroxysmal dystonia, and if it's brought out by movement, it's kinesogenic. It's just a Latin term brought out by movement. So paroxysmal kinesogenic dystonia is an entity that we recognize. There are a number of different kinds of abnormal movements that patients with dystonia have, and this is one of the sources of confusion. Remember I said it's easy to say somebody's got dystonia if their neck is twisted and it's always twisted, but what happens if it's jerky or irregular? What happens if it's slowly writhing? And the term athetosis is used for slow writhing movements, or rapid shock-like jerks. That is often a source of confusion. Rhythmical movements that look like tremor can often be very confusing, and this is a source of a lot of confusion and diagnosis and a lot of argument on the part of academics. Academics like to argue with each other, mainly because we don't understand. The more you don't understand, the more you argue and have an opinion. It's really quite remarkable. And then there are other kinds of movements that may be seen in various different dystonia syndromes. So all of this confusion encouraged a group of us, including Dr. Stanfon, to meet several times. We had a beautiful meeting in a lovely villa in Rome for one weekend. And then after that, we met several other times. And in 2013, we wrote this paper, Phenomenology. That's a term you may not be familiar with. Phenomenology means what we see, the characteristics of movement. So this rhythmical movement is a tremor. So we recognize the phenomenology of tremor. We recognize dystonia, we recognize fast jerks, etc. So the phenomenology and classification, we had a consensus meeting and wrote this paper. First and foremost, we redefined dystonia. And so we recognized that this was a movement disorder characterized by the sustained contractions that were recognized for centuries, but also intermittent contractions causing abnormal, often repetitive movements, postures, or both. Dystonic movements are typically patterned, and anyone in the room knows this already, right? You generally have the same kind of movement over and over again. It may be different from your next door neighbor with dystonia, but in you, that movement is very patterned and rather predictable. And so the patterned nature of dystonia is quite characteristic. It often is twisting, but what we recognized also is that it can be shaky and tremulous. And that's something that hadn't been acknowledged to that point. Dystonia is often initiated or worsened by voluntary action. And that's characteristic, but it hadn't been part of the original definition. And we also emphasize the association with overflow into muscles that are close by. So we redefined it. And then on top of the new definition, we decided to separate it into two axes. One, the clinical characteristics, and number two, the cause or etiology, and try to separate these two items out. Under the clinical characteristics, we define the age of onset, the distribution of the dystonia in the body, the pattern, the temporal pattern, and the presence of associated features that often help us decide what the cause might be. So the age of onset, we divided into 5 categories. It's kind of interesting. The group, and I'll tell you in a minute, has met again, and we're now revising the categories. And some of us, some of the younger feel that late adulthood, over 40, is not something they're happy with. So I think late should be anything older than me. And so that is a mobile target, I think we should indicate. So these are the ages of onset as they stand now. The body distribution, and I think I'll bring all of these up together because I don't want to spend too much time on it. But you'll see we divided it under focal, segmental, multifocal, generalized, and hemi. And the definitions for you aren't that important. Focal is just one body region. Segmental were two or more regions that are close by and are linked. Multifocal, obviously, is many different regions. Generalized, there's an argument about what should be generalized. Let's not waste our time because it's not that important to you. Hemi is really important, though. When you have half of the body involved by dystonia, automatically we think that there's a very, very high likelihood. If my right side has leg and arm, it's very likely I've got something wrong with my left brain that we can find. I've had a stroke or a brain tumor or something's going wrong on the left side of my brain if my right side is affected by dystonia. So hemidystonia is very helpful to doctors because it directs them in the investigations. The temporal pattern. We wanted to define how did the dystonia begin, suddenly and acutely, subacutely over weeks to months, or very, very gradual over months to years. And what is the course? Do you get it and then it stays the same? Is it static? Is it progressing? Or is it varying? Is it improving, fluctuating? And there are even patients who have what are called remissions, believe it or not, where they have dystonia for a period of time and then it goes away as strangely as it comes. And this is something we wish we understood more. It doesn't happen that often. It happens more commonly with certain forms of dystonia. But if we understood it, I think we'd understand a lot more about dystonia. Variability, short term, from hour to hour. Is it persistent? Is it action specific, as I told you? There are some forms of dystonia, particularly seen in children, that have what's called diurnal variability. And that means they can get up in the morning and function near normally, and by the end of the day, they're wheelchair bound. It's really quite remarkable. And when we see that, that's very characteristic of a form of dystonia that responds brilliantly to the drug we use in Parkinson's disease called levodopa. And it's a disturbance of the neurotransmitter in the brain, dopamine. The brain has an enzyme disturbance that doesn't make dopamine properly, and so we replace the dopamine with levodopa, and it is basically a curative disease, a treatment for this disease. And then I've described what paroxysmal is. Okay, so isolated dystonia is what we used to call primary dystonia. Remember I told you primary is you just have dystonia and that's all you have. We said primary is a bad term. It is confusing for various reasons, so we coined the term isolated dystonia as you see here. And this is the characteristics. So isolated means, let's see, yeah, this works. So it's the only feature you have, with the exception of tremor, because tremor is so common in dystonia, we decided it would be too confusing to exclude that. It is not paroxysmal. Remember, I told you the paroxysm comes like an epileptic event, and then you're well between. That doesn't happen in most forms of dystonia. We separate the paroxysmals out, and the term isolated dystonia isn't a form of paroxysmal. It can become present at any age. So we have isolated dystonia beginning in childhood all the way to 80s and 90s. So it can occur at any age and in any body distribution. And this includes the commonest forms of dystonia, which are probably the majority of people with dystonia in this room, are what we call adult onset focal dystonias, or segmental dystonias if you have more than one body part affected. And the cause is often unknown. That is a lovely term that you'll hear, idiopathic. Just simply means I have no idea what the cause of your dystonia is. So that's very common. And sometimes we find specific genes that are associated with these isolated dystonias. So this term isolated incorporates all of those features. So that's isolated. And then what we said was that if you got more than that, you have what's called combined dystonia. And dystonia can occur with other movement disorders. Remember, I told you dystonia can occur in Parkinson's disease. So if you have dystonia and Parkinsonism, there are a group of disorders that can cause that. It may be associated with other neurological abnormalities. We know that a number of brain diseases, you may present with dystonia, but you may have a variety of other neurological abnormalities, suggesting you've got a fairly diffuse brain disorder. Uncommon, and again, probably doesn't represent very many people, if any of people in this room, but it's still something we need to know about. And then some patients have dystonia with what are called systemic features. It's a very important genetic disorder that we always think about when somebody comes to us with dystonia, and that's something called Wilson's disease. And the reason that we think of Wilson's is that it's a treatable disorder of copper metabolism. You have a transporter in your liver that transports copper, and if you block that, you accumulate copper, you get cirrhosis of your liver. It's a different kind of cirrhosis than alcoholism causes, but you damage your liver and you also damage your brain because of too much copper. And it's really critical to diagnose because we have drugs that remove the copper. We de-copper patients with Wilson's. And so if you have liver disease with your dystonia, it's really important for your doctor to know that that's one of the causes to think about. Okay, so these are the characteristics that I've already told you. Age of onset, body distribution, temporal pattern, isolated or combined, and combined may be with neurological manifestations or systemic. Now, the second axis that we then considered, that was the clinical axis, number one. This is axis number two, and this is the cause or etiology. And we divided that, and this is kind of a strange thing, and we've had some arguments about whether this should continue. We included what we think is going wrong in the brain, the pathology. Is this a degeneration of the brain? Is this a static brain disease like a stroke? Or is this something that we don't really understand, no evidence of degeneration or structural lesion? So we felt it was important for doctors to acknowledge that and be aware of it. And then under that, we decided it's inherited or acquired. And so we divided that up, and you just see, again, you don't need to know all the details, but you might be interested in knowing the list of acquired disorders. You had a perinatal injury, in utero, cerebral palsy is a cause of dystonia, and that relates to a perinatal brain injury. Infections of the brain, a variety of drugs and toxins, strokes, a neoplastic, a brain tumor, injury, etc. So, now, what's happened is that over the last many months, the group here that is listed at the top has got together at a sort of a 10-year anniversary. You know, you get the club together and, you know, sing the old songs, but in this case, we decided it was time to relook at the classification and decide whether there were problems with it and what we needed to do to fix some of those problems. We had 10 years of experience using this definition and classification. And so what we've done here, and I'm not going to go through the details in any great detail or extent, but you see here, this is, whoops, no, let's go back. Here's axis one with the features that I've told you about already. We've revised the temporal dimensions that I'll tell you about in a minute, and we've added another component called phenomenology, and we've revised the associated features. The size of the red box tells you how much we've actually changed it. And then we made some minor adjustments to the axis too. So very quickly, this is how we've changed the temporal dimensions. Remember, we had onset and course. We've revised the course a little bit to indicate you can fluctuate. But now what we've done is added this variability, paroxysmal and diurnal, under the temporal dimension. So this was just an adjustment of the process or the definitions. And here's a brand new component. You recognize some of the features I've already told you about, but what we've done is emphasize this for the doctors that are using this. And here's the sequence of events that I've told you about. Is it task-specific, or has it progressed to being non-specific, movement-induced? Or is it now present at rest but varying? Or is it there sustained constantly? And there's this other term that is really important for us physicians to recognize, and that's what's called fixed. And fixed is the limb is in a position, and no matter how hard we try, we can't get it out of that position. And that's very uncommon for the isolated forms of dystonia. It is sometimes seen with very rare severe degenerative diseases, And it is sometimes, when we see a patient who abruptly has this, it's sometimes an indication of psychological problems. And so we can see patients that look like they have dystonia, and it's not a primary brain problem, it's a psychological problem, and that very rapid onset fixed dystonia is a clue to us that we might be dealing with that. And so we felt it was important to acknowledge that. And then given the frequency and importance of recognizing tremor, we added that and emphasized that it was not exclusive of the other categories. So we had to rate the other categories, but also rate whether the patient has a tremulous movement. And then we revised this a little bit, emphasizing that there were 3 options for it combined, and again, emphasizing you could have any one of those 3. So it's, again, these were not mutually exclusive, and I don't think I need to say anything more about the presence of tremor. Now this is, we're getting near the end now. We also recognized at the beginning, and we haven't really revised this, that there are many reasons for typically postures or positions that can be confused with dystonia. And this is really very important for us to convey to medical doctors, because everything that has a head turn is not necessarily a dystonia. So in fact, if you've lost the back part of your brain and you can't see half of your visual field, so you have an occipital lobe stroke, you often turn your head to take in more of your environment because you're not seeing over here. And patients with what's called a hemianopia will often have a turn like this. There are some patients that have a lesion to one of the nerves that supply the muscles that move the eyes, and they will often have a tilt to avoid seeing double, because the muscles that move your eyes, if you've got one that's damaged, you see double because you're not moving your eye muscles properly. So to avoid the double vision, you'll often take on that position, and it's sometimes mistaken for cervical dystonia or neck dystonia. And so you see here a long list of different things that could be confused with dystonia. Some of them are associated with excessive muscle activity. Rare diseases like Satayashi's syndrome, for example, very, very rare condition that can be mistaken for dystonia, and others aren't related to abnormal excessive movement at all. All of this then allows us to put patients into syndromes to help us make a diagnosis. And so you'll hear the term dystonic syndromes, and we've just listed some of these here. Again, the details aren't that important, but we see childhood or adolescent associated generalized isolated dystonia. If I see that, or Connor sees that, we think a very specific group of diseases. And there are genetic forms that we investigate immediately when we see a young child with nothing but isolated dystonia involving multiple body parts. On the other hand, very, very common, and I mentioned this at the outset, the commonest is seeing adults with isolated dystonia in a single or only 2 body regions, like cervical dystonia, cranial dystonia, laryngeal dystonia with the vocal cords. Those are very characteristic syndromes that we recognize are generally not associated with brain diseases. So for example, if you've got nothing but classical cervical dystonia, an MRI scan is not going to tell us a darn thing. And in fact, you're going to be very uncomfortable if you're trying to lie in the scan and keep your head still, and the technician is fighting with you to tell you to keep your head still, but your dystonia is preventing you from doing that. We don't learn anything from an MRI scan because we know they're going to be normal. I don't do MRIs in someone who has classical adult onset focal neck dystonia. But I look very hard for other neurological abnormalities that tell me that it's more than just a focal dystonia. So it's really important that the doctors understand these syndromes and the company that they may or may not keep. If you've got dystonia with Parkinsonism, that raises a whole group of conditions that we have to think about. And then there's this condition where muscle jerks can be associated with dystonia. Myoclonus means fast muscle jerks, like shock jerks. And when we see that associated with dystonia, there is a small group of conditions that we have to investigate, mostly genetic. And so again, it's a syndrome that's important for neurologists to recognize. And why is it important to recognize these things? This table sort of tells you, if you've got dystonia in childhood, you more commonly develop generalized multifocal, and less commonly, so the hatched bar just simply indicates the frequency, segmental. So 50% of children that develop dystonia will become generalized or multifocal. And then you see over on this side, this is how commonly we find a cause. And actually, these percentages have raised since I've made this slide because we know more and more genes that can be associated with this. So childhood dystonia has a certain prognosis because we know it's more likely that they're going to get severe dystonia that will generalize, and it's more likely that we're going to find a cause when we investigate them. Whereas if you begin in adolescent life, you're more frequently more limited in the severity and the distribution of the dystonia. It's more likely it's going to stay segmental and less common that it becomes multifocal and generalized. And now the older you become, the less likely it is that you're going to find a cause. But again, as I told you, this slide was made before some of the genetic revolution, so these numbers are actually higher. Whereas as an adult, as I've already told you, it's very, very uncommon to become more widely spread. It's far more common to remain segmental or focal, and hardly ever do we find a cause. Whereas I've already told you, if you've got hemidystonia at all ages, you've got a very high likelihood of us finding a cause. Getting near the end, the natural history. What do you expect when you're told you have dystonia? Well, in fact, because dystonia is just a symptom of many diseases, obviously the natural history is going to vary depending on what the cause is. The severity of involvement of selected regions will help you understand the variability and the expected disability. The extent of spread to body regions also varies. The time course from the initial symptom to spreading to another body region also varies. So lots of variability, and that's why it's so hard for us to predict when you first come to see the doctor what to expect over the next 10 to 20 years. Those factors that we think of when we're giving you the prognosis, when you say, doctor, what do I expect? What am I going to be like in the next little while? Those features that we use are, if you've got a known cause, the etiology, that helps us immensely. Obviously, if it's treatable, I told you about the levodopa responsive dystonia of childhood. Great, I know that what I'm going to be able to tell that individual, they're going to respond to medicine and they're going to do extremely well. In somebody who presents with cervical dystonia as a late adult, you can also tell it's likely it's going to stay in that body region, and you may benefit greatly from botulinum toxin injections, for example. So the cause is very helpful. The age of onset, where it begins, and the distribution of the dystonia are all factors that combine to help us provide the appropriate or sometimes difficult prognosis. So I'm going to quit at that point. Thank you very much for your attention, and entertain any questions.
That was a wonderful overview of not just the classification, but really dystonia and our approach to it in general. There may be any questions in the audience. There are microphones that go around. I might quickly ask while they're going around. You hinted at this earlier in the slide. I know you've talked about it a couple of times at the International Symposium, the idea of lumping versus splitting and the importance of getting that balance right between lumping dystonias together and splitting. Would you mind making a comment on?
So the emphasis that Connor is pointing out is that a lot of studies trying to understand dystonia, understand the mechanisms, what's going wrong in the brain, and obviously the more we understand, the closer we're going to get to treating it a lot better than just using things that weaken muscles, for example, botulinum toxin, although it's really provided a revolution in the way we treat. So the more we try to understand these conditions and split them out, probably the better. But then there's still an argument for lumping too, and so we don't know where the line really should be drawn, and it probably depends on the nature of the investigation. What we need are much larger multinational studies that bring large groups of patients together. I think we need to study them agnostically, not study them as if we understand, and that's one of the biggest problems. We come to our research with preconceived notions, and those preconceived notions may be wrong. And so what we need to do is bring large numbers of patients and then do lots of investigations imaging, electrophysiological testing, a variety of things, and try to use the results of those tests to help us subdivide. And right now, I look at a patient and it's the eye of the beholder. And I may assume that this person that looks a bit like that person has the same thing, and we may find they're totally different when we fully understand the condition. Gentleman here with the microphone, without them.
Good afternoon. Thank you for that talk. That was very informative.
Thanks.
We are the parents of a daughter who has chronic pain and has now developed dystonia. Well, not now, but some years ago developed dystonia as well. Now, one of my questions would be, if we look at the causes of dystonia, is there a direct link to chronic pain?
So some dystonias, remarkably, despite the severe abnormal postures, have no pain at all. And then other dystonias where the posturing isn't all that bad, the pain can be profound. And so it's very difficult to subdivide and understand that at this point. And I think that's another group of patients that we really need to understand. Now, there are many reasons for people having pain, too. And so we have to take the individual and try to understand the individual before we sort of say, well, dystonia and pain must be related and must be the same thing.
My daughter would have had several spinal implants over the years to try and control her pain. Is it possible that has contributed to her dystonia?
I guess it's possible. Everything's possible. I don't want to say yes, don't want to say no.
Okay. She also is on quite a lot of strong medication in terms of painkillers.
Well, certainly drugs, selected kind of drugs, can be associated with dystonia. Typically, pain medication, analgesics, or narcotics generally don't cause dystonia. But there are other kinds of medications for nausea or for psychiatric purposes. Those kinds of drugs may be, and they may be part of the drugs she's received. So you just have to have them looked at carefully.
Okay. Infection. Again, she's had several infections following surgeries, and she's now seems to be at the stage where her immune system is severely compromised. Again, there's a lot of things going on here. I'm just wondering.
Sounds very complicated.
Is it a combination of them?
Obviously, you need to be seeing specialists that can get at the details. In terms of infections, I was really referring to primary infections of the brain.
Oh, okay.
And so those may be associated. Having a pneumonia or some other kind of infection related to a previous surgery, that generally isn't associated with dystonia.
Okay. That's all. Thank you very much.
You're welcome. Hi.
Thank you very much for that. It was most informative. I am here representing my husband, who statistically wise has appeared on the screen there. At 61 years of age, he was diagnosed with truncal dystonia, but in actual fact he was diagnosed with truncal-like symptoms of dystonia, which for perhaps 1 year in his life, the first year, doctors would have recognized it as a problem with the back because they never figured out the front. But as time went on and through various stages, it was diagnosed as truncal dystonia. And that too can send, because of the, domino effect between the spasms in the truncal area are attached to the back. So he finds it very, he cannot sit for long stages. And there is pain, but he can manage. It's quite, how shall I say, put it, he has to do a lot of mental working on the brain to try and keep, how will I say it, you talk to your spasms or talk them down. And that is most evident at night time going to bed. When he hits the bed, obviously because he's in
certain positions,
a certain position, the spasms will lessen, but they don't lessen immediately. He's got to level them down.
Well, just to address a couple of things quickly, and one of the challenges in these kinds of meetings is being specific to an individual's problem. And it's probably best I not, without seeing your husband, best that I not say too much specific. But number one, you raise the fact that the tremendous variability and stress particularly will accentuate symptoms of dystonia, as it does all movement disorders. And so this is a very common experience that patients have. Some dystonias, as I mentioned, are painful, and truncal dystonia can be quite painful. There is a differential diagnosis, and that's why you need to see a specialist, and I hope he's in good hands, because there are other conditions that can look just like that. There's a condition called stiff person syndrome that would have to be excluded, and I'm assuming that his neurologists have considered that already. Management of trunk dystonia, which is one of the less common adult onset dystonias, so it's rather uncommon, is very challenging. The injections may help. We usually use medications as well, and this is where deep brain stimulation of the brain might be a consideration too in the hands of experts in the field, and that's why he needs to see experts.
Thank you. Thank you.
That was very interesting. I just have a question just in relation to the prevalence of, I suppose we'll call it, use your original word, of primary dystonia, or isolated dystonia, I think is the current term.
Very good. You've learned.
Yeah. In relation to a other movement disorder, because you mentioned obviously the audience here, and I expect the majority probably have just got primary dystonia, but I would have a movement disorder where cervical dystonia is part of it. The other part has been quite complicated in relation to finding out that other element. But I suppose my question is, I'd be involved with the Neurology Support Centre and have met a number of people with movement disorders. I was wondering, is there studies done to say what the prevalence is of dystonia as part of another movement disorder, in other words, not isolated as a standalone condition? And if there has been, is Parkinson's the most likely to have that? Because I know from in-person meeting people through the Neurology Support Centre, that seems to be the other neurological movement disorder that has dystonia in meeting people as part of it.
Yeah. So there have been a number, but there still needs to be more epidemiological studies to determine how common these problems are. There are a lot of patients that are misdiagnosed or don't go to a doctor. So if all you have is a funny problem with writing, you may think, well, who would be interested in that? You don't get to see the doctor, and then no one knows that a group of people out there has a form of dystonia that hasn't been acknowledged and evaluated. Parkinson's is one of the commonest forms of movement disorder. There's a tremor that's called essential tremor. That's another complicated topic, but that's probably the commonest. Tourette syndrome is another movement disorder. It has psychiatric problems as well as neurological problems. That's very common. Tics. So there are quite a large number of different relatively common movement disorders. Adult onset focal dystonia, if we take the group, and here's the lumping versus splitting, if we lumped everybody together, it's a fairly common group of patients now.
One more question at a time.
Oh, yeah. Can you get it there? Oh, sorry. Can you,
Sorry. Hello, how are you? Very interesting talks there, I have to say. I feel I've had dystonia for so long I could get up and talk to you all. Back in the 70s, early 70s, I was diagnosed with spasmodic torticollis. Never heard of dystonia. I was seen in Limerick Hospital. I was sent to Cork to a neurologist. Nothing was found there. I was seen also while I was there by a psychiatrist, and I was told it was my imagination. I lived with it for years. Then in the 80s, I went for alternative medication, acupuncture, chiropractor, osteopath, etc. Again, I lived with it for many years. And in the 90s, I didn't allow it to take over my life. That's one thing. I just dealt with it, kept it there. In the 90s, I began to hear about Botox and dystonia through some other people. Again, I shelved it. I put it on the shelf. I didn't want to consider it. But then at the end of the day, I did. I went about it. And I started Botox injections. But really, fast forward, as I say, I don't want to be too long. I could write a book on it at this stage. Fast forward to last December, I got the dreaded thing, COVID. And I dealt with that for a couple of weeks, and I was getting out of it, getting over it, and I got a violent pain in my neck. So it pitched in the weak spot, as they say. I was spending the night in A&E and all the rest of it. I went to my neurologist, Helena Moore, and I had an MRI in my head and my neck. Now I've been left with a numbness down my left side, and I still have that numbness. So I blame that on COVID, but it's because I had the weakness in my neck. I think, anyway.
Yeah. So you raise a few points that I'll try to address. The first is the long journey that you had, and that's very, very common. Misdiagnosis, thought to have a psychological problem primarily. And in fact, I told you that there is a group, uncommon, of patients where it is caused by a psychogenic or psychological cause, but that's very uncommon. And in fact, many young people with dystonia, childhood onset dystonia, were told that it was psychological. They're in a wheelchair and they're told it's because their mother didn't treat them correctly when they were growing up. And this caused all sorts of harm and psychopathology with that misdiagnosis, and blaming the family and blaming the dynamics that happened in the family. So the pendulum swung way over to not consider it a psychological problem, and it was only after a long time that actually Dr. Fawn again recognized that there was a small proportion that were actually psychologically induced. So then the other thing you mentioned is botulinum toxin brought a lot of patients out of the woodwork. And so we had a treatment, and now we began to realize how common these problems are, because patients had nothing that was offered to them for treatment, and now there is something. And then family doctors began to wonder. They heard about botulinum toxin, wonder, is this patient my patient that I've been dealing with for a long time? Could this be dystonia? So we began to see a lot of people that had gone years and years and decades without seeing a neurologist because nothing else to offer. The final point you raise is the role of COVID, and that has had a negative impact on patients with almost every neurological disease. And it's remarkable what we've lived through in many respects. Just the fact that we're sitting here without masks on and hugging my ex-fellow and seeing my friends at this meeting is just such a wonderful development after this misery that we've all had to live through. And when people have been infected by COVID, it's not been uncommon to have a negative impact on their underlying neurological disorders, so you're not alone.
Sorry, could I just ask Professor one more question? Is dystonia still in its infancy with a lot of neurologists? In its infancy with a lot of neurologists? You mean people don't know about it? Or? Are there specialized neurologists? Well, dystonia is what we call a movement disorder. The field movement disorders, it's actually quite rare now for an academic center, a center that has a university affiliated, not to have specialists in movement disorders. So in fact, it has grown immensely since the days of the history that I told you about. And Dr. Fawn, again, was one of the world-renowned. He actually was being recruited. I know Stan very well, and he's told me the story a couple of times. He was living in Philadelphia with another very famous neurologist by the name of Bud Rowland. And Rowland was recruited to lead neurology at Columbia in New York City. And so he recruited Stan back to New York with him, and Bud said, I want you to do the Parkinson's clinic. And Stan said, well, I do much more than Parkinson's disease. I see these patients with dystonia and a variety of other things. I don't want to call it a Parkinson's clinic. And so Bud Rowland said, well, why don't you call it movement disorders? And so that term came from this guy by the name of Bud Rowland, and Stan Fawn ran the first movement disorders clinic, really gave birth to the field, and people like me and subsequent generations are growing up now with academic centers doing this. So we recognize it, we teach our students, and so it's pretty uncommon for somebody coming through a neurology program not to have heard a lot about dystonia, fortunately.